So today will be the fourth session on neuroradiology. I thought the sessions will be over by now, but no, somebody requested for a class session on neuroinfections. So we'll be try to cover as much of neuroinfections as possible today. Next slide. Next slide. So coming to the first scenario, 30-year-old man presented with fever, altered sensorium, and seizures. MRI was done. Next slide. So this slide shows the CT and the MRI. Can somebody tell me what the finding is there in the CT and what the diagnosis is?
Yeah, Dr. Asta, you can try answering.
Yes, sir. Sir, here in the background of fever, altered sensorium, and seizures, here we can see that the first two images are of top two images are CT scans showing heterogeneous space occupying lesions, sir, in the right temporal lobe, which is showing hyperintensity in that. And ma'am, answer in the lower two images, we can see the T2 images, where again we can see heterogeneous space occupying lesions, which are showing hyperintensity within.
See, when you are describing it as a space-occupying lesion, is it when the parenchyma itself has got an altered, whether it is a hyperdensity on the CT or a hyperintensity on the MRI, we don't call it as a space-occupying lesion. You can say it as a lesion, but in
Yes.
fact, space-occupying lesion, you don't use it to describe a signal alteration involving the cortex.
Yes, sir.
So what you can, like you started, you can say that the CT is showing a hypodensity. Can you go to the image only, please? So you can say that the CT is showing a hypodensity involving the right temporal lobe with a hemorrhagic transformation, and the MRI is also showing a hyperintensity and a swollen cortex and subcortex involving the right temporal lobe and a part of the frontal lobe. So the diagnosis is quite obvious. So what is the diagnosis?
Sir, as is a acute history of fever, altered sensorium seizures, and temporal involvement is there predominantly. So infective like herpes simplex encephalitis.
Okay. So if it is herpes encephalitis, which herpes virus it is? Is it HSV1 or HSV2?
Sir, one is commoner, one is more possible here than two.
Like herpes simplex encephalitis is the most common cause of fatal sporadic necrotizing viral encephalitis. So there are two types, neonatal type and the adult type. In adults and older children, mainly this is type 1 herpes simplex virus, like you said. And so there is an asymmetrical involvement of the temporal lobe and part of the frontal lobe. Whereas in neonates, it is mostly type 2 herpes simplex virus, and there is a diffuse brain involvement. So, you have here an adult patient who has presented with a febrile illness followed by altered sensorium. Then the most likely diagnosis is type 1 herpes simplex virus. Next slide, please. So HSV1 is responsible for 90% cases of HSV encephalitis. HSV spreads via lingual nerve to the trigeminal ganglion. And when there is some trauma, stress, infection, or some situation, then the viral reactivation occurs and it spreads to the adjacent brain structures via the trigeminal nerve. So the characteristic pattern you have seen, there is asymmetrical involvement of the bilateral limbic system, and part of the frontal lobe also may be involved. Next. So here you have the CT scan which shows asymmetrical hemorrhagic necrosis of inferior frontal and temporal lobes. This is again the MRI picture, which is showing hyperintensity and swelling of the affected areas. Both cortex and white matter is affected. In addition to that, there may be a diffusion restriction and some patchy contrast enhancement.
Yeah, you can continue.
So in HSV encephalitis, there is T2 and flare hyperintensity involving the medial temporal lobe. And also there can be involvement of the inferior frontal lobe. There is usually sparing of the deep gray nuclei. So we have already seen that there can be patch diffusion restriction and also some swelling up of the cortex and the white matter. Hemorrhagic changes may be seen. So what are the imaging DD of herpes encephalitis? Other viral encephalitis like EBV, primary brain tumors, most commonly a low-grade astrocytoma, limbic encephalitis, which can again cause asymmetrical involvement of the medial temporal lobe, arterial or venous infarction, and even after status epilepticus, you can have involvement of the medial temporal lobe, and this may mimic herpes simplex virus encephalitis. So here, you have some imaging DD of herpes encephalitis. Tell me what are the possible diagnoses in these situations? Image. Am I audible?
Yes, sir.
So the first image I have already shown you that it is showing a case of herpes. Do you try images B, C, and D? What is the finding and what is the diagnosis? Possible diagnosis. Dr. Asta?
Yes, sir. Sir, in the second image, there is again a medial temporal lobe hyperintensity on the left side.
Okay.
So one possibility is, depending on the history, so autoimmune, that is limbic encephalitis.
Yeah. So what I want you to focus there is that, so, the involvement of the frontal lobe, even though it is not visible here, usually in limbic encephalitis, there will be involvement of the medial temporal lobe only. And also compared to in a case of HSV encephalitis, the swelling will be lesser in a patient with limbic encephalitis. So the second one is a patient of paraneoplastic limbic encephalitis. What about the third image? C.
Sir, in C image, there is a predominant involvement of the right cortical region of the temporal lobe, sir, with some extension to the frontal lobe also.
Is there an extension to the frontal lobe?
No, sir. It is only the lateral temporal lobe of the right side, which is hyperintense, predominantly involving the cortical and the juxtacortical white matter.
Okay. So the strictly respecting the arterial territory, you have involvement of the lateral temporal lobe. So what is it?
Sir, it can be a superior division NC infarct.
Correct. So this is a flare hyperintensity involving the anterior right temporal lobe. So there is a right MCA infarction. Now, what is image D? What does it show?
Sir, here we can also see that there is a hyperintensity in the right frontal region.
Right frontal?
Left, sir, left temporal, there is a gyral thickening and sulcal effacement, sir, on the left temporal side.
Yeah, so
Left
there is a hyperintensity involving the left temporoparietal cortex, and there is, like you said, there is a sulcal effacement and there is a swelling of the gyri. Yeah, the images D and E are from the same case.
B and D, sir.
D and E.
Okay, sir. So there's a possibility of left transverse sinus thrombosis.
Correct. So this is like we discussed in the earlier class, where there is a typical arterial territory. So here there is a patient with a left transverse sinus, venous sinus thrombosis, and there is again the arterial territory will be respected. So this is another patient who is a case of astrocytoma. So here you can see there is involvement of both medial and lateral temporal lobe. The gyri are swollen up. There is a flare hyperintensity. So this is a patient with an astrocytoma, which can again mimic a patient with herpes encephalitis. So this table will give you an idea. So when you compare the DD of herpes encephalitis, a medial temporal lobe involvement, which is unilateral or asymmetrical. When it is symmetrical, it is usually bilaterally present, but it is usually asymmetrical in a patient with herpes encephalitis. A similar picture you can get in a patient with limbic encephalitis also. Whereas you get a unilateral involvement of the temporal lobe. It can be medial temporal lobe or lateral temporal lobe in patients with arterial infarct. And venous infarct also, again, the distinct venous territory is there. So unilateral involvement in astrocytoma, arterial infarct, and venous infarct, whereas unilateral or asymmetrical bilateral in herpes encephalitis and limbic encephalitis. The deep gray nuclei will be typically spared in patients with herpes encephalitis and astrocytoma, whereas it can be affected in limbic encephalitis, arterial infarct, and venous infarct. Hemorrhagic changes may be present in herpes encephalitis, arterial infarct, and venous infarct, whereas usually hemorrhagic changes are absent in astrocytoma and limbic encephalitis. So again, another thing I will add here, that mass effect is usually minimal in patients with astrocytoma and limbic encephalitis, whereas mass effect is common in patients with herpes encephalitis. Post-contrast enhancement is usually seen in herpes encephalitis. It will be a patchy contrast enhancement. Limbic encephalitis also, it may be present. And as you all know, in the subacute stage of an infarct, there may be contrast enhancement. And that is the stage where these infarcts may be commonly mistaken for mass lesions. The history is very important. So in a patient with herpes encephalitis, there will be a preceding acute febrile illness, whereas in the other situations, it might not be there. Sometimes febrile illness can lead on to situations where patients have venous infarct. So that is another possibility. Even arterial infarct, because we have a lot of patients with COVID and all who are developing strokes. So, but usually when you take it, the preceding acute febrile illness will be for a patient with herpes encephalitis. And the onset is acute in herpes and in arterial and venous infarct, whereas astrocytoma and limbic encephalitis is subacute. Limbic encephalitis, can be even a prolonged duration of illness. Extracranial neoplasm will be present in patients with limbic encephalitis. So with this table, you will be able to reasonably differentiate what is the etiology of a the temporal lobe involvement. Coming to the second scenario, who will be taking this case? Any volunteers, or Dr. Asta wants to continue?
Yes, sir.
Okay, so 46-year-old presented with fever and altered sensorium. Clinical examination showed a patient who was very drowsy, hypokinetic, slow, and there were some abnormal eye movements on examination. This was the MRI. What is the diagnosis? What is the possible diagnosis or the differential diagnosis?
So here we can see bilateral thalamic hyperintensities on the T2 weighted images and T1 also. So here possibility of bilateral medial thalamic infarct, atrioperitoneal infarct is one possibility. On the background also fever, there could be a Japanese bee encephalitis or dengue encephalitis.
Very good. So you have a T2 flyer and flyer leash and flyer images, which are showing hyperintensity of thalami, and the third image there is no contrast enhancement. So this is a typical patient with the Japanese encephalitis. So patients can present with an acute onset extrapyramidal syndrome, a kinetic rigid syndrome. So Japanese encephalitis, as you all know, is caused by a single-stranded RNA flavivirus. The reservoirs are domestic pigs and wild birds spread by Culex mosquitoes. And bilateral thalamic involvement, it can be visualized in CT or MRI. The other regions also may be involved, like basal ganglia, substantia nigra, red nucleus, and pons. Hippocampus, cerebral cortex, cerebellum may be involved in rare situations. So this is again another case where you have bilateral thalamic hyperintensities, which can show variable diffusion restriction, might not be always present, and there can even be hemorrhagic transformation. Can you tell me some differential diagnosis? So you already said that the medial temporal lobe involvement in artery of Percheron infarct. Can you tell me some other DDs of a similar presentation where the patient has bilateral thalamic involvement?
So one is deep venous thrombosis of the deep venous system.
Okay.
Then, sir, among the viral infections, even the dengue encephalitis and influenza encephalitis can also lead to similar pictures.
Very good. So this is a patient. So this is a patient with a dengue encephalitis. So you can see the symmetrical, thalamic involvement. Usually they say that the mass effect will be more prominent in a patient with the dengue encephalitis compared to a patient with the Japanese encephalitis. Continue. So artery of Percheron infarct, deep venous sinus thrombosis, dengue encephalitis. What else?
Sir, even West Nile virus.
Definitely good. West Nile virus.
Influenza virus. Sir.
Okay. Influenza virus. Okay. West Nile and dengue. That's what usually call. So the basal ganglia and thalamus involvement. That pattern is usually seen in West Nile, dengue, and Japanese encephalitis. These three. Any other differentials come to your mind?
Sir, metabolic causes like vernix can sometimes lead to such pictures.
Very good, very good. So the other differential diagnosis, main things will be flavivirus encephalitis like dengue and West Nile. Even herpes simplex encephalitis can rarely present like that. Rabies encephalitis. So rabies is another situation where thalamus, basal ganglia, and sometimes there can be the swelling up of the cortical gyri also. And like you said, deep cerebral venous sinus thrombosis. Now coming to the third scenario. 26-year-old presented with fever, myalgia, followed by double vision, ataxia, and difficulty in swallowing. So this was the imaging picture. All of you people can try. You feel free to make mistake. Dr. Asta is if she wants to continue, she can. This time, if you make a correct diagnosis, it will help you a lot. It is just before your exam. So, feel free to make a mistake. Many of these things I also learned while I'm preparing for the presentation. Can somebody describe the finding? If you know, even if you don't know the diagnosis, that is fine. What do you see in this picture?
Yeah, Dr. Anusha, you can try.
Sir, there is a hyperintensity in the bilateral temporal lobes with there is hyperintensity in the pons, pontocerebellar junction.
So the dorsal pons, the temporal lobe, it is not a prominent thing, but there is the involvement of the dorsal pons. If you can see, there is hyperintensity. This image also shows that, like almost like a mustache, it is present. The dorsal pontine hyperintensity is present. So this is a patient with the enterovirus encephalitis. So brainstem is the most common site of involvement in patients with enterovirus, and out of brainstem, the most common site is the dorsal pontine tegmentum. The most common neurological complication in enterovirus encephalitis is rhombencephalitis. Can you tell me which part of the cerebral cortex is affected in a patient with enterovirus encephalitis? So the image showed you that the patient's brainstem is affected.
Temporal, sir.
Is it good for you? See, the examiners will be quite cruel. I just wanted to point that out. The patients are usually, supratentorial involvement is not usually seen in the enterovirus encephalitis. That is a very big differentiating point. So usually it is the brainstem. The cerebral cortex, the frontal temporal parietal lobe, these areas are not affected in enterovirus encephalitis. So, if you have a brainstem involvement along with cortical involvement, then the differentials change, like rabies and all you have to think. So here in enterovirus encephalitis, you have T2 weighted and flare hyperintensities involving the brainstem, most commonly the dorsal aspect of pons. The other areas are mentioned here. Even spinal cord involvement can be there, and it is one of the most common viral encephalitis causing acute flaccid paralysis. So like I mentioned, there is no supratentorial involvement. So this is again a patient with enterovirus myelitis with anterior horn cell involvement, which led to acute flaccid paralysis. So here, this is one of the differentials of enterovirus encephalitis. Can you tell me what else can cause a similar picture?
Listeria.
This is, like I mentioned earlier, this is both images are of the same patient. This is the patient with rabies encephalitis. So rabies can affect the dorsal pons, the thalamus, the basal ganglia, and sometimes there can even be cortical swelling. So it is a close mimic. So if supratentorial involvement is there along with the rhombencephalitis picture, then rabies is one of the differentials. Now coming to the next scenario, you only can continue. 46-year-old man presented with progressive cognitive impairment for past 4 months. He also had weight loss of 6 kg. On evaluation, he was found to be confused, slow, and ataxic, and he had extensive oral candidiasis. So I think the possible diagnosis is quite obvious, right?
Yes, sir. Immunosuppression, HIV.
So maybe immunosuppressed, he is, maybe HIV is one of the causes. So what do you have in these images?
Bilateral diffuse subcortical white matter hyperintensities, right, so left more than right, sir.
Okay, so you have
Periventricular.
very good. Asymmetrical periventricular subcortical white matter hyperintensities you have. What else? Some atrophy also is there. No, there is no mass effect. There is atrophy and there is no mass effect. So in the setting of the, so you already mentioned, so this is a patient with the HIV dementia complex, or so usually it is due to direct infection of the central nervous system, and HIV leads to a subcortical dementia. Patients present with psychomotor retardation, executive function dysfunction, abnormal gait, urinary problems the patient will present to you with. The MRI, like you mentioned, it shows symmetric confluent white matter hyperintensities. The important thing that you have to keep in mind is that there will not be any mass effect. There will not be any enhancement. So if such a patient is there and the patient has got, you start the patient on treatment, and then you do the MRI, and if there is enhancement of the subcortical white matter hyperintensities, what is the diagnosis?
Iris, sir.
Can you add something to the iris?
Cryptococcal.
Not cryptococcal. Cryptococcal does not cause a confluent subcortical white matter hyperintensities. No, what I am saying is that the patient has got a white matter hyperintensities which were not contrast enhancing. You start the patient on HIV treatment, and then you do the MRI, and there is a contrast enhancement. So what you said initially is correct. Iris. What iris?
Enhancement is there, means
PML.
blood-brain barrier should be PML.
PML iris. So PML also usually there is no contrast enhancement, but in the setting of in iris, when you start the patient on ATT and the immune system receives a boost, at that time there can be contrast enhancement. Significant atrophy is common in patients with advanced HIV dementia. So this is what we mentioned. In the left-hand side, you have the HIV-associated dementia patient with symmetrical periventricular hyperintensities, and the right side, you can see that there is no mass effect or enhancement. Coming to the next scenario, a 54-year-old man with HIV presented with confusion, apathy, and weakness of his left arm for 3 months. He had discontinued his HIV medications for a long time. So what is the finding and what is the diagnosis?
Here bilateral cortical and subcortical hyperintensities were there. Here right more than left. Involving the corpus callosum also and basal ganglia. PML, sir.
Correct. So this is a patient with a progressive multifocal leukoencephalopathy. What is the causative virus?
JC virus, sir.
Yes. So here you have confluent white matter lesions in the frontal lobe bilaterally and throughout the temporal and parietal lobe. And again, here there is no mass effect. And like you mentioned, it is crossing over to the other side. The corpus callosum is affected. The lesions are the last image. If you see, you can see that the lesions are hypo-intense on the T1 weighted image. So PML is caused by JC virus, a Papua virus. The people who are affected with PML are late stage AIDS, so with a CD4 count of less than 100, and patients with multiple sclerosis who have been treated with natalizumab. That is why you tend to know, even if a patient is doing well on natalizumab, after some time you switch that patient to some other immunosuppressant to make sure that the patient does not develop a PML. So here again, this picture shows that the asymmetrical involvement of white matter, often involving the subcortical U fibers. And here you have the T1 image, which shows the hypointensity. So it is T1 hypointense and T2 hyperintense, and there is no mass effect. There can be mass effect when the and enhancement when, like in the scenario that we mentioned earlier, when the PML develops in the setting of iris after initiation of highly active antiretroviral therapy. So this is a patient who has developed a contrast enhancement after initiation of antiretroviral therapy. This is the patient with PML iris. So what is the sign? Can you know what? So the PML in the earlier images, we saw that it was affecting the supratentorial space. So the frontal lobe, the temporal lobe. But here in these images, in addition to that, there are multiple hyperintensities affecting the cerebellum, the cerebellum, the thalamus, the basal ganglia. They are also affected. This is also a patient with PML. Can you describe this sign? Can you see my pointer? What is this sign?
Sign, I don't know, sir. There are multiple punctate hyperintensities.
Very good. That sign is also described as a punctate appearance. So this is a described named sign in PML. It is also called as punctate appearance. What do you see by the side in that corner? What do you see?
It is like,
so this is called the Milky Way appearance or punctate pattern. So you have multiple hyperintensities. This can be, need not only be in the cerebellum, anywhere it can be present. So here in these images, you have multiple hyperintensities, like we mentioned in the cerebellum, the basal ganglia, and the cortex. Can you name this sign? What do you see first? This is also a patient with PML. You can see the white matter hyperintensities in this T2 weighted image. So we'll describe what you see about what is specific about the white matter hyperintensities.
It is in the subcortical white matter posteriorly in the occipital and going to the parietal region, involving the splenium also, but the U fibers are spared here. Sir.
Okay, so the corpus callosum is also affected. Yeah. So what is the sign?
don't know the science.
So this is known as the barbell sign. So there, like you mentioned, there are confluent flare T280, the T2 hyperintensities involving the parieto-occipital cortex, and there is a continuation across the splenium of corpus callosum, and this is called the barbell sign. So so we have discussed various viral encephalitis. Japanese encephalitis we saw where the basal, where the thalamus is affected. We saw again a differential with a dengue fever patient who had involvement of the bilateral thalamus. So these are the typical areas. The cortical gray matter, the medial temporal lobe, orbitofrontal cortex, insular cortex, cingulate gyrus, these will be affected. Then you have to keep HSV in the differentials. Basal ganglia and thalamus, the common viruses that affect are Japanese encephalitis, West Nile, and rabies virus. Brainstem and spinal cord, anterior horn cells, the patient can present with an acute flaccid paralysis, enterovirus, rhombencephalitis. Cerebellar involvement is seen in patients with mycoplasma, varicella zoster virus, dengue, and rotavirus. Subcortical white matter will be affected in patients with HIV virus causing HIV-associated dementia and a patient with a progressive multifocal leukoencephalopathy. Can you tell me, out of these viruses, which is the virus which has got a predilection to cause a vasculopathy? Patients can present with aneurysms. Patients can present with infarcts or aneurysmal bleeds. Which virus has a predilection to cause vasculopathy out of this?
Varicella zoster, sir.
Yeah, very good. So varicella zoster virus infection, when you have, always explain slightly bad prognosis to the patient. They can suddenly deteriorate, and make sure that you do an angiogram. If vasculopathy is there, means then the prognosis might not be very good. Now coming to the next scenario, who will be taking the question? Dr. Anusha, you want to continue?
Yes, sir. I'll continue. Sir.
Okay. 40-year-old man presented with headache, vomiting, double vision, and ataxia. There is history of 6 kg weight loss. So a very nice, familiar MRI picture for you. What is the diagnosis?
Sir.
Look at the the patient's history. So there is a 40-year-old man. There is features of raised ICP, brainstem involvement. There is 6 kg weight loss is there. And now look at what is the area of involvement. You focus on, look at the finding, and you look at what area of the brain is affected.
Anterior part, basal exudates, sir, basal region of the brain,
Very
and the basal ganglia.
So in and around the brainstem, it is affected. There are basal exudates, and you can see ring-like lesions also, no?
Yes, sir.
So we are coming into the rings right now. So this is the first ring.
Yeah, TB, tuberculoma, sir.
So yeah, so this is a patient with a TB meningitis. So you can see the extensive basal exudates, the ring-like lesions, the contrast enhancement, the mass effect, which is extending. So in the basal meninges. So this is a patient with tuberculosis. TB meningitis most commonly affects the basal meninges and manifests with cranial neuropathies, primarily of the abducens nerve and altered mental status. So here again, this is the post-contrast image which demonstrates large number of ring-enhancing lesions throughout the brainstem and brain. And below you have the flare images which are showing the mass effect and the edema due to the tuberculomas. Now coming to the next scenario, 45-year-old man presented with 2 episodes of focal to generalized seizure, which was followed by headache and vomiting. So a well-preserved patient who has suddenly developed seizure, followed by which he has some raised ICP signs.
It's a neurocystic sarcosis, sir.
Okay, so can you, enlighten me further and say, this left side, what stage of neurocystic sarcosis you are seeing here?
Vesicular stage.
Okay, which one is vesicular?
Sir, the one which is
This one.
no, sir. The one which is in the right hemisphere.
So this is a vesicular stage you are saying?
No, sir. That is granular, sir. The one which is in the right hemisphere.
Oh, right hemisphere. So the one in the right hemisphere, this is
Vesicular stage, sir.
But no, and so why do you say that this is vesicular and both look the same? No,
Edema is not there, sir, here in the right side.
in the right side, you have a ring lesion, and
Mhm.
what do you see there? There is no
There
edema.
inside, there is no edema. Inside, I could see some scolex, sir.
Inside you can see scolex. Very good. So there is no edema. Inside you can see scolex, and on the right hand side, what is the difference between these two lesions?
Sir, in the one which is in the right hemisphere, the enhancement is somewhat less than that which is in the left hemisphere.
Very good. In addition, so they, I will explain it here only. So on the right hemisphere, you have a lesion in which you can see the scolex inside. The lesion, there is no edema around it. And in the contrast enhanced image, there is lesser enhancement. And one very important thing, the wall is thin. Okay. So vesicular lesion, the wall will be thin. Whereas, so this is the second stage is the left side. You have a colloidal vesicular stage where there is edema around the lesion, and also the wall is thicker and contrast enhancement will be more. So this is a patient with, like you said, the neurocystic sarcosis caused by the CNS infection with the pork tapeworm, Taenia solium. The stages are referred to as the Escobar's pathological stages. So the first stage is vesicular. So in vesicular stage, there is a viable parasite, there is intact membrane, there is no host reaction. The second stage, there is a colloidal vesicular stage where the parasite dies. It may either die due to your treatment, or it may die spontaneously. The wall becomes thick, there is surrounding edema, and the patients can present with seizures. So this is the stage at which patients usually present to you. In the granular nodular stage, that is the third stage, the edema decreases, the cyst becomes smaller in size. You cannot see the scolex inside. The enhancement persists to a degree. And in the last stage, which is the nodular calcified stage, there is no edema. So in the first and last stages of neurocystic sarcosis, vesicular stage and nodular calcified stage, there is no edema. The size of the lesion will be small in vesicular and in nodular calcified stage. So colloidal vesicular and granular nodular, this is the time when usually the patients present to you either with seizures, or headache, raised ICP signs. So like I mentioned, this is again a CT and MRI T1 sequence. So the ideal sequence to visualize a vesicular stage where you can see the cyst with the dot sign due to the presence of the scolex, that is a T1 sequence. So in the CT again also you have a cystic lesion with the scolex that you can see clearly inside. There is thin vesicular wall, there is no enhancement, there is no surrounding edema, and most common site where these occur are at the gray-white junction. This is the second stage. There is the colloidal vesicular stage, which you are seeing in the CT. So here you can see the CT, which is showing the lesion and there is surrounding edema. And here you can see a contrast image, which is showing a thick-walled cyst, which is enhancing. So this is the MRI picture of a patient with a colloidal vesicular stage. You can see the extensive surrounding edema around the lesion. And here you can see the thick-walled lesion with the surrounding edema. The enhancement is much more than what you see in the vesicular stage. This is the granular nodular stage. So here, you have to carefully look to see this granular nodular stage lesion. But when you give the contrast, it is more easily identifiable. So there is thick-walled cyst. The size of the cystic lesion usually decreases. Edema may be present, but it is less than the colloidal vesicular stage. Cyst retracts, eventually becoming a small enhancing nodule. This is the MRI, which is showing that the edema is less compared to the vesicular colloid vesicular stage, and there is less enhancement. So this is the nodular calcified stage. So in the CT, can you describe the sign that you see here?
Starry sky.
Yeah, the starry sky appearance. So this is the end stage of a quiescent calcified nodule, no edema, no enhancement. And sometimes there can be enhancement, like you see in this particular image. You can see the flare hyperintensity is there, and also there is enhancement. And if there is a nodular calcified lesion which is causing enhancement, the chance of the patient having long-term seizures is high. So this is what you mentioned, that it is a starry sky or a starry night appearance. There is some other description which is given to a patient. The image that you see here, other than starry sky, is there other some described name to this appearance? So it is called the Swiss cheese appearance. Okay. So starry sky appearance or starry night appearance and Swiss cheese appearance, both are the large number of neurocysticercae when you are seeing. That is the appearance. And this is the name given to the presence of cysticercae, multiple cysticercae inside the fourth ventricle, and it is called the racemose or grape-like neurocysticercosis in the fourth ventricle. Now coming to the next scenario, 50-year-old.
Pardon. How to treat that starry sky NCC?
Yeah, Dr.
And
Anusha.
in which NCC steroids are contraindicated?
Sir, if there are these number of multiple cysticercosis, steroids can be given, sir, but you should not give albendazole because there is more of inflammatory reaction and patient may throw into seizures.
Yeah, if the live cyst, your vesicular stage or your the cyst, the parasite, if it dies, the inflammatory reaction will be so severe that you will not be able to save the patient. So usually we tend to end up giving only steroids. Dr. Shailesh, what was your second question?
In which NCC steroid is contraindicated?
That I also don't know. Dr. Anusha, you can enlighten us.
No, sir, I don't know, sir.
Ocular NCC.
Steroid is called.
Because if there is edema, there is chances of vision loss.
Yeah, in ocular NCC, albendazole is contraindicated, right? Steroids are contraindicated.
We have to check once.
Somebody
asked during the exam.
I think albendazole is contraindicated, I believe, because if they
only steroid we have to give.
Only steroid in the patient with an extensive large number of neurocysticercus and also in ocular neurocysticercus. Both of these situations, especially if it is a live one, we don't give albendazole. And
how to treat this racemose?
Racemose surgery, sir. If it is surgery is if we can take it with surgery, surgery can be done.
Yeah, the patient sometimes they can present with sudden hydrocephalus like in a colloid cyst. So endoscopic resection of the racemose cyst, neurocysticercae can be done.
Yeah. Okay. Good.
Okay, so 50-year-old HIV positive patient discontinued antiretroviral therapy and now presented with headache, vomiting, seizures, and weakness of right upper limb and lower limb. So this is the MRI. This was asked to me for my exam. So it is one of my favorite images.
There is one space occupying lesion in the right frontal lobe with the diffuse edema surrounding it.
Yeah.
Cryptococoma, sir?
Not cryptococoma. What do you see?
A target, yeah.
Yeah. Toxoplasma. So now, before you go ahead further, I will ask you the second question that they asked me. Can you, out of neuroinfections, can you tell me a differential diagnosis for this? Patient does not have neuroinfection. So this is, like you said, this is a patient with toxoplasmosis. Is there a close DD for this?
some variant of demyelination.
Ballos and concentric.
Ballos concentric sclerosis, no? So that also will look like this, but the edema will not be this much. And also, like we mentioned, no, the patients with Ballos concentric sclerosis, the prognosis will be quite poor. So this is a concentric target sign, which is typical for cerebral toxoplasmosis, typically seen in a T2 weighted image, and there are series of concentric rings with hyperintense and hypointense signal alternating, and the edema will be very significant. Edema and mass effect will be there. Toxoplasmosis, as all of you know, is caused by the intracellular parasite Toxoplasma gondii. It's the most common cause of cerebral abscess in AIDS patients. Cats are the definitive cause. So, the Toxoplasma is one of the first things that you have to test when any patient with HIV, AIDS comes to you with an opportunistic infection, a meningitis. The first thing that you should test for is Toxoplasma. And if everything is negative, you are supposed to treat for Toxoplasma first before you think of it as cryptococcosis. Empirical treatment you initiate, the first thing that you have to treat is Toxoplasma. So can you describe this sign? So I did not animate it properly. So this is eccentric target sign in cerebral toxoplasmosis. So one question is lost. So can you describe what you are seeing?
There is a ring enhancing lesion, sir, with surrounding edema. And inside the ring enhancing lesion, there is central hyperintensity followed by a hollow surrounding it.
Yeah, so it is supposed to arise from the wall of the lesion. So, the enhancing mural nodule, and the abscess wall, it is extending, and it is pathognomonic for cerebral toxoplasmosis. The eccentric target sign is seen only in some 20 to 30% of cases of toxoplasmosis, but you can say with a high degree of certainty that it is toxoplasma itself. So here again, you have toxoplasma lesions, which are typically seen scattered around the basal ganglia. That area, it is usually more commonly seen. So here you have again a patient with a basal ganglia ring enhancing lesion. What I want you to focus is on is the CT. So this hypotensity on CT helps us to differentiate toxoplasmosis from another entity. What is? A flare hyperintense lesion involving the basal ganglia with significant mass effect and contrast enhancement. You have a ring-like lesion. The CT is showing high hypodensity. So this hypodensity helps you to differentiate it from one close differential diagnosis in a patient with HIV. What is it?
Crypto.
You remember me talking when the last session, when you have hyperdensity, it indicates a cellularity. So like neoplasms, so in neoplasms and all, like in lymphoma, if you do a CT scan, there will be hyperdensity. So this is a lymphoma, and you can see that the CT is showing hyperdensity due to increased cellularity. So primary CNS lymphoma and the CNS toxoplasmosis are close differentials. So can you tell me some pointers which help us to say that the lesion is toxoplasma or the lesion is lymphoma? One, I have already told you that it is showing that the CT is showing a hypodensity in a patient with toxoplasma, whereas in a primary CNS lymphoma, there is hyperdensity on the CT due to increased cellularity. Tell me some other differentiating points.
More mass effect and edema in lymphoma, sir.
Really?
In the lymphoma enhancement, more mass effect and edema.
More mass effect?
With surrounding edema as it's a tumor, it can.
Okay. What else? See, toxoplasma also will have significant mass effect. Now, you saw that in that patient with the concentric target sign, that much edema is there. Mass effect is there. Significantly, it is there. No? What else? each sequence you bring to your mind. What happens in the diffusion? What happens in the when you give contrast? Each sequence. What is the difference? The location.
In contrast, yeah, location toxoplasma more of basal ganglia, sir.
Okay.
In enhancement, it is like ring-like enhancement in toxoplasma. This can be diffuse enhancement in lymphoma.
Okay. Good, very good. You are attempting. All of you people, during when I was studying, I was always very hesitant during these times to answer. I did not want to make a mistake. So it's quite, it is to be appreciated that all of you people are coming forward to give answers. All of us make mistakes, but you have to try to give answers. So these are the differentiating points. So CNS toxoplasmosis, you saw that the lesions are usually multiple. Even single lesion may be present, but it is usually multifocal lesions. See, lymphoma, you have a solitary lesion. And if the previous image you see, here, you can see that it is there is no the ventricle is not affected. So in CNS lymphoma, there will be a typical subependymal spread, whereas toxoplasmosis, it is scattered through basal ganglia and the corticomedullary junction. CNS lymphoma, like you mentioned, there is a solid enhancement, whereas in toxoplasma, there is a ring-like enhancement or a nodular enhancement. Hemorrhagic transformation in an SWA sequence or a gradient sequence may be seen in toxoplasmosis, whereas in lymphoma, it is uncommon. Brilliant diffusion restriction in a patient with CNS lymphoma, whereas in toxoplasmosis, there is facilitated diffusion. MRS can help with increased choline in CNS lymphoma, and like we saw in the image, there is hyperdensity on the CT in CNS lymphoma. So here you have a so these are various images, different patients with lymphoma. So in the first image, you have a hyperdense lesion in the CT, and you have a brilliant contrast enhancement in the CT, which is showing a contrast enhancement, T1 hypointense, T2 hypointense with a diffusion restriction and a homogeneous contrast enhancement. So that you keep these images in your mind, and you will be easily able to identify whether it is a lymphoma or not. Always there can be lymphoma, there can be close mimickers. Biopsy is definitely needed. Without that, we cannot proceed. So coming to the next scenario, 54-year-old man presented with headache, fever, and left-sided weakness. What is the diagnosis? So we have gone through some of the rings: tuberculosis, neurocysticercosis, toxoplasmosis. So this is another ring-like enhancement. So describe the images and then go for the diagnosis.
There is a ring enhancing lesion in the right frontal lobe with the diffusion restriction with surrounding edema. Looks like cerebral abscess, sir.
Yeah, so you have a lesion with a significant edema around that, a thick walled lesion, which is with a brilliant proper diffusion restriction. So this is a patient with intracerebral abscess. So there is a large ring enhancing lesion, and restricted diffusion is present, and the ADC is showing reversal. So the stage, what are the stages of abscess formation?
Cerebritis stage.
Yeah.
Then capsule forming stage, the necrotic stage.
Capsule formation happens in third stage. So there is early cerebritis, late cerebritis, early encapsulation, and late encapsulation. One similar thing, like we told earlier in NCC, in early here same way in the initial stage of the NCC, vesicular stage, there is no mass effect, there is minimal enhancement, and the size of the lesion is small. So in early cerebritis also, there is very little mass effect and minimal enhancement. And in the last stage, again, there is less edema and the size also reduces. So in the second and third stages, that is late cerebritis and early encapsulation, there will be significant mass effect and enhancement. So the first stage, early cerebritis, I have not put an image here. There will be little mass effect and minimal enhancement. you need to have a high index of suspicion to pick up an early cerebritis. This goes on, and the patient, the lesion develops a central a necrotic center and significant amount of edema and a significant enhancement, and then the capsule formation sets in. Well, image that I projected initially, and then you have a mature abscess and the edema is less compared to that. So this is a stage 2. So you can capsule, there is hyperintensity, there is patchy diffusion restriction, and this is the stage 3, early encapsulation. Here you have multiple lesions and there are additional daughter collections, and there is significant mass effect, not mass effect, significant edema around the lesions. And this is the late encapsulation. So you can see the well-formed lesion. In the flare image here, you can see that the edema is lesser around the lesion. Okay, so that concludes my presentation. So thank you. If there are any doubts.
Thank you, Dr. Kurian, for simplifying this presentation for neuroradiology and neuroinfection. How to differentiate between pyogenic and TB abscess.
Can you tell me once more?
Pyogenic versus tubercular abscess.
Who wants to take the question?
Lipid peak in MRS, sir.
Size, number, size. MRS you can say at the end, no? In the beginning you can say the other things. Do you want to answer?
Somebody types multiple small abscesses goes in favor of pyogenic abscess.
Reverse, no? Multiple lesions, multiple abscesses will be favoring TB. Pyogenic will be usually single. Correct, no, Dr. Shailesh?
Probably. Sometimes difficult, but daughter cyst and conglomeration more in favor of TB.
Okay.
And sometimes depends on clinical features also. If patient is very toxic, high-grade fever, and that more goes in favor of pyogenic. And if patient is slightly stable, then probably chronic infection secondary to TB. What else, Dr. Kurian, you can tell?
Mostly it depends upon the number of lesions. I think TB you can have multiple lesions which are usually small, whereas a pyogenic you will have the lesser single lesion, and usually the lesion size of the lesion can be quite large. Mass effect will be more in a patient with a pyogenic abscess, and mass effect will be lesser in TB compared to a pyogenic abscess.
Yeah, and depending on the other X-ray, CT scan, chest, ESR, and all also.
Yeah, and the location also, like you have a basal meningitis, so in infratentorial, posterior fossa involvement in a patient with tuberculoma. Cerebral abscess is more commonly involving the supratentorial. The cortex is usually affected.
Yeah, and how to differentiate blooming in the toxoplasma versus fungal?
Blooming in
Toxoplasma versus fungal.
Toxoplasma versus fungal. I will also have to read and tell you.
Because both are close differentiation. And sometimes it is very confusing in NCC, TB, and toxoplasma. That difference.
That is something that really one Dr. Sharat Sir's one class is needed for difference. It's quite volatile, but when you listen to the class, it is quite informative. TB versus NCC.
Yeah. You have any link for that?
I had actually, but I tried to, for preparing for this presentation also, I was searching for that and I could not find it. If I find it, I will definitely share it here.
Okay. And how to differentiate versus starry NCC versus miliary TB?
Miliary TB. Okay. See, NCC will be cystic, and miliary TB, it will be like rice grain nodular type of lesions which are very much scattered. Calcification will be more common. The CT that you show, miliary TB, the calcification will be less common compared to a patient with the NCC where there is a starry sky appearance. So I think these things will help you to differentiate, and also the location. The gray matter white matter junction is what is usually commonly affected in NCC. Miliary will be diffusely involving everywhere, and the posterior fossa also might be affected. So the location, size of the lesion, cystic appearance versus kind of nodular appearance, large number of lesions again in miliary also. So that will help you to differentiate.
Yeah. Anybody have any other question? Okay, if there are no questions, we can close the session. Thank you, Dr. Kurian, and thank you everyone for attending this session. We can close the session.
Thank you.
Okay.
Thank you, sir.
Somebody asked some question. 1 minute. Probable date of exam after Diwali, after IronCon.
Anyway, I think this is the last session. I had already said goodbye. So anyway, best of luck everyone for the exam. Please do well.
Best of luck everyone. Prepare nicely. Give more focus on cases, and all others are this table viva, neuroradiology, EG. They are just for namesake. More you have to focus on cases. Every case is having 50-50 marks. Total 300 marks. So that is more.
Your fate will be decided during the case presentation.
Yeah. This spotting and table viva, they are just for namesake, but cases, initial 2 cases are very important.
Yeah.
And remaining 2 cases mostly conventional exam pattern. 4 cases. Some exam center like St. John's, they will have first 2 cases very important, and next 2 like differential diagnosis, how to manage.
OPD patients and all they will bring. Simple trigeminal neuralgia, cluster headache patients and all they will bring and keep for exam.
Yeah, and it depends on also which examiner is coming. If some stroke specialist or some movement disorder specialist or headache specialist or epilepsy specialist, they can keep their own case. They can select their own case sometimes.
Yeah.
So 4 cases in some Delhi center, every cases will be semi-long.
And also when you are going to present, be ready. Sometimes they will tell you, tell me the diagnosis. So rather they will not allow you to present.
Yeah.
Don't get stumped at that. That is one place where everybody gets stuck.
Yeah, initial first 1 or 2 case, they will ask in detail. But next 3rd and 4th case, only diagnosis, differential diagnosis, and how to approach the case. First 2, they will ask in detail history, how to exam, like that. And after that, some people are keeping spotting initially before cases and remaining table after cases. And they will in some centers, all the people are like in St. John's, everybody will be at one table only. But in Delhi, they will divide 2+2, 2 examiner at a time, one case, and 2 examiner at second case, and table also like that. But in St. John's, like if it is there, then all the 4 examiner will be there simultaneously for each case and each table.
All examiners being together is always the best thing.
Yes. Necessary instrument already we have forwarded. We'll forward again.
Okay. Thank you.
Do not try to take any. Means cheating is not allowed. If somebody will see, then it will be negative impression. And try to check BP in all the cases. Sometimes some examiner like Kalita Mishra madam, they will ask the patient whether doctor has checked your BP or not. And sometimes this per rectal examination and private part examination are very important during the spinal cord cases and some cauda equina cases. Okay, Dr. Kurian, you can.
Okay. Thank you.
Okay, then we can close the session.
Okay, Dr. Sailesh. Thank you.